So what's interesting about these various risk stratifying algorithms is that we have 5 or 6 different features, and we then are bucketing people into good, intermediate, or poor risk. And there's obviously going to be a lot more granularity to it than that. And for example, in the TKI literature, there's evidence that intermediate 1 feature versus intermediate 2 feature, that there's a difference in outcome. And then from good to intermediate, there's also perhaps a little bit of a fine line between those. So at this point in time, I think I look at this, whether or not the individual's tumor biology is one that's kind of more of an intermediate risk in terms of how it's affecting them, how rapidly the disease is growing. So I think it would be more sort of a measure of disease aggressivity that I would use as a measure of true quote-unquote intermediate features as opposed to good risk features. And that would help me make my decisions on how to treat.
IMDC risk is pretty defined, and the factors that lead one to categories as poor, intermediate, or favorable risk are really straightforward and easy to assess. I think with a clinical biomarker that good, it doesn't really behoove us to kind of say, well, it looks like you're poor risk, but really I think you're favorable risk, or you're intermediate risk, but you're behaving like a good risk. So risk is risk, and I think you assign it and then you have to sort of go from there. That being said, I could imagine an intermediate risk patient where we advise either observation or just a single agent VEGF because of other factors, right? Because they don't really want treatment. Length of life is not their goal. They want quality and they feel well and they don't want to interrupt that. That's someone who might elect observation even if they're in an intermediate risk category. So it's really patient to patient, and one of the hardest things meeting a new patient in a vulnerable situation where they're just diagnosed with cancer is trying to really get at what their values are and learn what's important to them to really help guide them in decision making. I think it's easy to say, you're intermediate risk, you should go on Axipempo, we're going to start next week. And sometimes that's the right thing. Often it's the right thing. But until we get to know the patient and their values and where their priorities lie, we can't really have a meaningful discussion about treatment.
So in terms of practical considerations for treatment at this point in time, do I make a big distinction between good risk and intermediate risk? Because a lot of the patients that I would be treating with good risk features, I'd be giving an IO-TKI combination, like axitinib plus pembrolizumab, and I would be potentially doing that for a favorable intermediate risk patient as well. It means that I don't really treat those individuals very differently. If the distinction would be between, for example, sunitinib and ipilimumab nivolumab, there it becomes a little bit more important, because if you look at the Checkmate 214 study in the good risk patient population, patients on sunitinib ended up having better progression-free survival, better objective response rate, albeit slightly lower complete response rate compared to ipilimumab nivolumab. But as I said before, that distinction becomes less important when you're thinking of an IO-TKI combination versus a TKI.